let's do this. And so this is being recorded and this is updated for you as well. And so on your slides, you're seeing some things that I'm hoping that you will understand by the end of this lecture. And so I just want to sort of show you some little things that occur at the level of the skeletal system. That's some things like gigantism, or the it was sort of an endocrine function that kind of causes a hormone to cause bone to grow. And so this is, I don't remember this man's name, but this was the largest, tallest man that has ever come to existence. And then you can see that you can have sometimes some syndromes where only some bones are more elongated than others, or more slender or thinner. And then you can see that we have dwarfism. And so my hope is that you can understand this text by the end of this bone section. And so as we look at this region here, we have the periosteum and the endosteum. The periosteum, we always slightly touched over that it was going to be the outer layer of bone. When you are directly looking at all those bones that we've been learning about in lab, that first layer that you're seeing is referred to as the periosteum. The periosteum. And this periosteum is made out of two different layers, the fibrous and cellular layer. One is basically going to be exactly what it sounds like, where it's just going to possess fibers. And here we're talking about like collagen fibers, the protein fibers that we've been seeing throughout the course. And then we're going to have our cellular layer. And this is going to be where a lot of the cells are going to exist. That's why it's called cellular layer. And so simply, if you have that outer boundary, that's how we can understand our first function. Like any outer boundary of anything, it's going to be the first thing in contact with the external environment. So you can see how bone, or the periosteum, isolates bone from the rest of the tissues. You can see blood vessels outside of that periosteum. To speak simply. And so this will also allow for the innervation of blood vessels. You can see that there's some blue ones here. It's the only ones you can really see. Maybe some red ones in there. But otherwise, they all are going to represent, these are actually perforating fibers. I misspoke. And so they're not really shown on this diagram or anywhere on this. But just keep in mind that you will have to imagine blood vessels being innervated into that compact bone. Remember that last week when we were looking at bones, and I'm going to go ahead and just pull it up. Might as well just review it. Unit 2, and then here. And so when we were looking at all of this outside, this was our periosteum at the time before we took a closer look. Remember, it has two layers. And then we have all of these osteons, and we have all of these lamellae. And again, that's going to be the texture or the layout of the bone. Lamellae, the one that goes around, is circumferential lamellae. The one that sits in between all of these cylinders is called interstitial. And then all of these that are surrounding these central canals, which have blood vessels, are called concentric lamellae. That's the name of the bone layout. You can see it's concentrated, kind of like when you concentrate on a dartboard. And these interstitial means in between. And so these are called interstitial lamellae because they are in between these, like in between the osteons. And then lastly, don't forget that as we look at this image, what we have to envision is that we have to envision that the entire circular area, boundary, the rim of bone, if you make a transverse section, that it will be really tight on the outside, and that's going to be referred to as compact bone. Everything out here looks like this. That's what the outside looks like of the entire rim. And all the inside looks like this. And so this is going to be what we refer to as the spongy bone, or the trabeculae, which kind of has this cavernous, different appearance. But otherwise, the relevance of where we're at today, here we go, and here. And so the relevance of it today is that you see that all those central canals provide a pathway for blood vessels and nervous supply. And again, this is the outer edge of bone, so we can expect those osteons are going to have central canals, and therefore they're going to have a pathway for blood vessels and nerves. And as we keep going, you'll see that it's going to also play a role in bone growth and repair. there is this term perforating fibers, and we've seen the word perforating canals. And perforating is going to refer to these fibers, these perforating fibers are going to be referring to all the fibers that is embedded within all of this lamellae, and they originate at this periosteum. So this periosteum, to speak simply, it has anchors. It has anchors within all of those lamellae that we just talked about. You can see here's the one listed, circumferential lamellae. And for the sake of consistency, let me close all these slides and I can go back to this. And we can see our concentric lamellae is going to be this outside. So now with your imaginations, you can see that all of these little fibers here are called perforating fibers, all anchored to that circumferential lamellae. That connection is so tight that even when you tear off, like when you actually put an extraneous amount of force, the bone actually, the periosteum rips off with the fibers of a tendon or of a ligament, because that's how tightly attached your ligaments and your tendons are to this periosteum. They're anchored directly to the lamellae. So when you like get a tear or a tendon tear, typically that means that the tendon itself kind of ripped, but that attachment site, most of the time, the bone itself will come off with the tendon, because this is such a good attachment. And so with that, we move on to the inner layer, which is going to be a little bit different. It's not going to be complete like the outer layer. It's going to have individual little segments that vary in composition. Here you're seeing these little individual cells called endosteum. They're going to be made out of cells. You can see that those cells can consist of something that sounds familiar. They can be osteogenic cells. And osteogenic cells have the ability to turn into osteoblasts, or differentiate into osteoblasts, And so all of these osteoblasts, they're capable of doing what with bone? Building. Let the B remind you of that. And you can even see that very thing is annotated on this figure, that this blue light here, this blue color on my screen that you're seeing, this is unmineralized bone. That means that osteoblasts have placed an unmineralized bone here, which we call osteoid. So I'm hoping that you're seeing, or you're studying from over the weekend is coming sort of full circle, that we called osteoblasts, that their ability to produce bone is in two phases. They produce an unmineralized form, and then they mineralize it. And they mineralize it with that star ion of bones, which is going to be calcium. Remember that bones store calcium. So when they add calcium to this first unmineralized bone, it becomes mineralized with calcium, and then it becomes what you know as bone. And so osteoid and bone are technically the same thing. Osteoid will turn into bone, but first it needs the calcium to actually deposit and mineralize it. And so, next, with that in mind, let's go back to where we were. And those osteoblasts will build bone, but then they eventually are stuck inside of their tiny little cavities called lacunas, and then they mature into osteocytes. And their job is to regulate all the lamellae around them and to distribute any molecules that they might need, or anything that they might need to distribute to the other osteocytes through the caniculi. All right, so you can see how that first packet is a lot of fundamentals to understand what we're doing today. And then as we keep going, we're now reached our osteoclast. And with our osteoclasts are going to be the ones that crush bone. And so if we are crushing bone, that means that these are going to be responsible for breaking down. And so if we tie it with our first set of notes, again, for the sake of review, you can see that our osteoclasts, their abilities, remember, let the CL or the whole term clastos, which means broken. And so it removes and remodels matrix. Remember, it's capable of disintegrating this bone and releasing the calcium if the body needs it. And this is referred to as osteolysis. With that, we move on. Sorry, let me get rid of this. That's old. We don't need that. I think I just closed the wrong thing. Yes, I did. This always happens. And I forgot where I put it. Let's see. No, not there. And I didn't place it. Oh, it's right here in front of me. Cool. All right, and so as we move on, these little regions where there are these little divots or these little dips, these are going to be osteoclastic crypts. That's going to be this little indentation that you see. You can see that there's no layer of cells here, and that's all an osteoclastic crypt is, sort of a home. And so make sure that if I ask you, where do I find osteoclastic crypts? I'm going to place as multiple choice options endosteum or the periosteum. All right, so make sure you know where they are found. And so we're going to see osteoclasts play roles in exactly what we've been describing. Their ability to do is that they are capable of destroying bone, and so you can see that they come up in the remodeling process. And we're going to see the other cells come in for bone growth and repair, but the endosteum has the luxury of all the cells being in this area to get any functionality that the bone actually needs. So with that in mind, we also have to touch on our cartilages one last time. And so keep in mind there are 3 cartilages that we learned in this class. We've learned hyaline cartilage, elastic cartilage, fibrocartilage. Let's start with elastic cartilage because it's the one that I don't need you to really care too much about. Remember, elastic cartilage is known for the chondrocytes producing an immense amount of elastic, and you find it in the ear. There is nothing other than the fundamentals that you need. It's made by chondrocytes. The cavities are lacuna. Elastic cartilage is called elastic cartilage because its favorite fiber to secrete is elastic, found in the ear. Nothing else. Same thing you know for the lab. Next, you have fibrocartilage, which we slightly will be touching and slightly have touched on. Fibrocartilage is found between the intervertebral disc. Same concepts. Cartilage is made by chondrocytes. They all live in lacuna. And this tissue in particular lays its collagen in a unique way that allows to resist compression, or in other words, it allows for some cushioning downwards, right? Because we're always upright, and so these cushion this vertebra from this vertebra so that they're not wearing each other down from your daily activities. And that's the role of fibrocartilage. And when we look at hyaline cartilage, this is going to be the star of today. And when we talk about bone anatomy, this is typically going to be the main star of bone growth because it is going to serve as a framework, sort of a blueprint, and then bone takes over wherever you find this cartilage. But it gets left behind a little bit, and then it has some leftover functions once bone is done with it, and we'll get into those details. But something to know, remember that hyaline cartilage, one of the main locations that we learned about it was in the costal cartilages, which was found between the ribs. And also, when we discussed our bone structure, we also learned long bone anatomy, that at the end of these long bones, such as the humerus, you encounter articular cartilage, which is made of hyaline cartilage, which we already touched on, right? The costal cartilages connect to the ribs. And then again, this is on the joints, right? Because you're going to see next week, actually not, pardon, what's the bone that connects the humerus here? Yes, so that's the bone marking, glenoid fossa. What's the name of the bone? Scapula. And so to prevent grinding between the glenoid fossa and the head of the humerus, there's a little bit of articular cartilage, and I wish our bone models came with it. Maybe I'll make models or something for us to cover the head of it so we can get a good visual of that. But that is going to serve as like a sort of a friction preventing grinding of either bone. And so that's really the role of articular cartilage. And then you're going to see that it played a big role in the growth, right? Think about when you were a child, that your bones, your humerus bone, even as you look at a child, this brachial region is definitely different from the size of an infant. And so bones have to grow. And that's our topic for today, is how bones grow. And one fundamental understanding for that is that you need to understand that hyaline cartilage plays a very fundamental role in forming our first skeletal framework. These are the 3 forms of growth that you see: appositional growth, endochondral ossification, intramembranous ossification. And that's really the end of bone, is to really just understand what those types of growths develop into and what they and where how they grow. So let's move on into that. So some things that are going to have some characteristics that are going to resemble what we've been learning in bone is that we have to remember our Latin words, that if you have a little bit of cartilage in this circle, and in this circle you have this cartilage now, this cartilage is going to have a boundary, 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 boundary. That boundary and all our little chondrocytes are located in here, stuck in their little lacunas. They're all existing in there. And in that boundary where they're in, that is going to be called perichondrium. Nice and easy, just like periosteon, right? Oste was the Latin prefix for bone. Chondri will always be Latin. We learned this almost on day one. So peri, around, chondri, around cartilage. It's kind of what it means. And so the boundary of anything in cartilage, and look, I can even show you an image that we haven't even addressed yet. We can see that this would be an example of this. This is all cartilage tissue. This boundary would be the perichondrium. There might be some cartilage out here, so this would also be a perichondrium. So perichondrium essentially is just a boundary wherever you find lacuna and chondrocytes. This boundary is perichondrium. You can see a little bit later, we're going to learn about bone formation. So it's not perichondrium anymore. What does that word change into in bone here? It's a lot more simpler than you think. Perichondrium gets replaced by periosteum. And that's going to be the overall take home here, is that periosteum means the outside of bone, but the outside of cartilage is perichondrium. And so that's why we started our slides with this image here. Periosteum will always refer to the outer layer of bone, not of cartilage. When it's cartilage, we call the actual layer outside perichondrium. Now, you do not need a lot of this, but some of this is going to be useful in a little bit. So we're going to apply this, and this, feel free to put a do not need for this box here. It gets complicated enough in a bit. And so understanding what chondrocytes are doing is going to be the same overall logic as osteocytes and osteoblasts. If it's called chondroblasts, that means that they're builders. And more than likely, we don't call them mature. And when they turn into chondrocytes, we consider them mature. You can see once surrounded by matrix, chondroblasts mature into chondrocytes. Remember, blast means to build new whatever it is. If it's osteoblast, they build a bony matrix, a bony area around them. If it's osteoblast, they build a bony matrix around them. I think I might have said the opposite right now. Chondroblasts build a cartilage matrix around them. Osteoblasts build a bony matrix around them. And again, the difference between a bony matrix is that it's calcified, right? It has calcium and collagen. That's a big difference between the two. With that in mind, they have the same overall function. Like when they build it, they get stuck in their own matrix. They get stuck in there, and that's why we know the term lacuna, because as they build it away from the edge, they end up getting stuck in their little lacuna. But you can see that they build a layer, they're building a layer, they're building an even larger layer. And so you can see that this is increasing the size. And so something that I really want you to take home from just this region is that whenever the edges are really growing, whether it's outside or inner edge, we call that appositional growth. And this is really the take home for there. It occurs at edges. That's the take home. And I think chondroblasts, we understand chondroblasts build, or they're the builders of cartilage. And then chondrocytes are the mature maintainers. I'm trying to write upwards. It's a little hard to get. It's going to be a little tough sometimes here. Mature. I'm not sure maintainers is a word, but it seems right now. Mature maintainers. They maintain the area. They're also considered mature chondro cells. And so those are the only take-homes. Know the role of chondroblasts, know the role of chondrocytes, and then also know just the basic definition of appositional growth, because we're going to see it again. And as we look at interstitial growth now, this word matters to me because the word interstitial is something that I feel like I struggle getting all of you to understand. And this word simply means in between. We're going to see this word. It'll come up over and over and over again. And interstitial simply is like, if we look at not care about the edge right now, because that was the key highlight of appositional growth at the edges. Now we don't care about that. Now we care about within the cartilage. In the greater context of things, if we look at this image, you can see that this is a rough image of a lacuna, and a little chondrocyte would be in there. Chondrocyte, lacuna. And so if you're growing deep within here, you are doing interstitial growth. But if you are growing out here, then if you're growing that way, then you are doing appositional growth. That's what we mean by the surface or the edge. And then when we say interstitial, it means that it's a chondrocyte that's stuck in here, and he's just dividing in here. He's actually just building and dividing. And so to understand that, when they're in the middle like that, all they do is that they divide within their cells. They make a complete copy of themselves. We call that mitosis. That's going to come up after lecture exam 2. We're going to bring that back. And so you're going to see that when these cells divide, they're going to divide into two, an exact copy of itself. Then they're slowly going to start building cartilage in this direction, and this one's going to do in this direction. And logically, you can expect that they are going to separate because they're sort of pushing each other away with the cartilage that they're building. And so that's really the overall, what this picture is representing. You can see they built new matrix, and you can see that they've expanded. And that's how you can get more chondrocytes to make more chondrocytes. You can see that we didn't have to go from chondroblast getting stuck in there to turn into chondrocytes. If the body needs it, it will actually let these chondrocytes divide within to actually build new chondrocytes. And so that's a major fundamental difference between interstitial growth, is that the chondrocytes are dividing within the lacuna plus within matrix. When we refer to a cell cloning itself and it creating two exact copies of itself after, this going from this to going to this, we call each one of these daughter cells, the copies of the cells. And they begin to secrete that matrix and move apart. And with that, the rest you do not need. Do not need. I want you to focus more on bone more than anything, and also this just helps introduce some hard concepts that we're about to face. All right. So with that in mind, now we are going to address those 3 methods by which bone grow. So you can see they're relisted here for you. I had originally touched on it at this point because hyaline cartilage will serve as the blueprint for some of these, but you'll see not for this one. And that was that sort of, I wanted you to get that note a little bit earlier, and I placed it here again for you. So let's go one at a time. So the reason I want you to know appositional growth is because we see it also with bone matrix. That appositional growth, if we look at a hollow, right, the compact bone, inside of this is the medullary cavity where we see the yellow marrow, the fatty tissue. And on this outside, you can see that you have all your osteocytes, and we have the periosteum, which is going to have cells that are capable of converting or differentiating into osteoblasts. So we also have that in the center. And so when you look at appositional growth, you have 2 edges. That is the key thing about the word appositional. We are focusing on edges. Inner, or rather, more appropriately, endosteum, plus outer, which you should all know as periosteum. And so as we examine our photo, let me get this. We are focusing on edges, inner plus outer, and inner is the endosteum, outer periosteum. And so as you can see in this diagram, before we even really get into the details, you can see that it's expanding from this edge and this edge, that we have some new matrix, some new lamellae laid out for the concentric canal, or that central canal to lay out lamellae, a new concentric lamellae. And you can see that if it's occurring at the periosteum at the outer edge, we have our circumferential lamellae. And so it adds circumferential lamellae. And actually, I misspoke right now, sorry. When we look at this very center here, and we might as well touch on that because I don't want to confuse anybody like I probably just did. When we look at our picture of compact bone and the different textures or different lamellae, we had interstitial, we had concentric, and right now by accident I said this one, but that is incorrect. Right now what we are evaluating is the outer layer and the inner layer, the endosteum. And so appositional growth is only focusing on circumferential lamellae. And remember, these two, the outer and the inner, is circumferential lamellae. Circumferential lamellae. All right, and like again, outside, periosteum, inside, endosteum. But each one has a boundary of circumferential lamellae. And so with that in mind, you can see that it adds circumferential lamellae to the center of bone, and it also adds it to the periosteum. And I wish that this was a little bit larger. This should be way more larger to express that, but whatever. All right, so as we move on, there's really nothing more to add other than appositional growth is going to result in increased bone diameter because we're only adding to the inner and the outer layer. We're adding circumferential lamellae. And we know the basics. We know that osteoblasts, as they're building it, they get stuck in it and then they turn into osteocytes, the basics. What's the unmineralized form of bone that osteoblasts lay down? Osteoid. And then what do they need to add it to? What do they need to add to it to turn it into bone? Calcium. They need to calcify it. And so with that, if we look at what's going on during infancy, you can see that your bones will increase in diameter because it is undergoing appositional growth. But there is something that must change, that in some instances, most instances, that when you need to increase the size of this medullary cavity. As another little quick review, that on the inside of these bones, inside of this medullary cavity sits yellow marrow, where my red highlight, I know it's kind of, wish I could turn into a yellow laser, but I can't. This should be yellow marrow. That is where we have adipose tissue. When your body needs energy reserves, it grabs it from there. And here at the very ends, you see red bone marrow. And so you can see that as you get older, you need to increase those medullary cavity, the size of that medullary cavity, because you need to be able to store more fat for when you might need it. And so, as you can see, as a child, you can see that when this diameter during appositional growth, that it also is removing bone matrix. And we know who's removing matrix, who destroys and degrades bone, are osteoclasts. And so whenever we see osteoclasts removing matrix at the inner surface, you can expect that it'll enlarge the medullary cavity. Enlarge the medullary cavity. Sorry. And so now when we say bone matrix is being removed, we know the stars of the show there. When we say bone is being deposited or built or some sort of making more, osteoblast. All right. And so that's the first one. Not too bad, right? The next one is pretty terrible. And this one is called endochondral ossification because it implies on the, what is endo, what direction? Inside. What does chondro probably imply? Cartilage. So inside cartilage. Let's write these little notes because sometimes the names can help us with some facts. Inside cartilage is what this word translates to. And then ossification is bone building. Remember, ossification means to build bone. What am I doing? Bone building. Yes, so first, the name itself is implying that we are going to encounter a actual cartilage being used first and then being replaced by bone. And that's what this whole term implies. And so the take home of this is that cartilage was used as a blueprint. Another word for this is kind of like scaffold. You've all seen construction sites, and you can see that all houses are made of like wood, and the skeleton is just made of wood before they add all the drywall and the outer paint, but it's just wood. That's exactly what I mean by cartilage is serving as a blueprint or a matrix, is that there's a lot of stuff that has to be added on top, but at first, that's exactly what it is that you start off with cartilage and then it's replaced by bone. And so in this instance, let's actually just go in with the pictures because it'll be a little bit easier. So first, big facts. So, another reminder of our basics to help make this easier to understand is that if we look at our previous slide, this whole segment, this whole page was dedicated to something we refer to as long bone anatomy. So it's talking about really the femur, which I know that we have yet to discuss that in lab. And then we have the humerus, which is going to be the bone that we have addressed of the upper appendicular. And so you can see that these were categorized as long bones. And so when we think about this very page, what we're really thinking about is how the long bones come to be. And so as you can see in this photo, our starting point really is in the fetal skeleton. And for those of you not familiar with this word, this means that the embryo or an egg and sperm is still developing in the womb. The baby that's developing in the womb, inside, it hasn't been born yet. I'm hoping that you guys understand what the word fetal means. And so fetal, here now, again, this is developing in the womb. So you can see that cartilage is first used to make a blueprint. You can see a lot of these things are already things that you are aware of. Here's what will be the humerus. Here are the two bones. What's the one that's going to be medial on the pinky side? Oh, pardon, this is going to be thumb side. Sorry, thumb side, lateral side. Radius, and this one. Ulna, these are all going to be making what cage? Thoracic cage. What's this bone that holds probably this bone here? The scapula. So a lot of this is forming. And so you can see the femur, and again, a lot of these long bones. And so that's the focus, is long bone formation. And so we begin now. Let's add numbers to this to make this a little bit easier. And so number one, when we look at our photo, you can see that we start off with nothing but cartilage. And then you can see that all of it is made out of hyaline cartilage. So that's step number one. We start with hyaline cartilage as our bone model. The next thing we see is that we start seeing blood vessels. I'm going to put a 2 here, and I'm going to we see blood vessels, and I'm going to use the word that we learned last class, innervate, which means, again, to embed itself, And so it embeds itself onto these edges, and you can see that what follows is going to be ossification. You're going to already see that a little bit of that periosteum is already starting to form. And so you can see some more clearer regions, epiphyses, diaphyses. And again, let's do a quick reminder of what those are. That when you look at any long bone, you have an epiphyses, one that's proximal, one on the other end called the distal epiphyses. And again, that's going to be the ends of the bone, distal for the one that goes down, proximal for the one that's further up. And then there's a little region called metaphyses here, little tiny region highlighted in red. And then we see another metaphyses highlighted in red in this little region. And then we have the diaphyses, which is what we've learned as the shaft in lab. It's the same word. You can use them interchangeably in the lab if you want. And so you can see we're seeing those same things starting to form. And we move on. Now, this blood vessel, you can see that its effect, when it arrived at the edge, it caused some bone formation. And so let's link these up together to make our notes a little bit nicer. Sorry if you wrote that. I'm going to put this, I'm going to put this, and this, right? Plus and plus, they go together. That when the blood vessels innervate, they cause bone formation. I wish I could find a way to put those together in hindsight, but yes. That's step number 2. And you can see that the effect or the trend continues, that the blood vessel innervates further deeper into what will be the medullary cavity. And so because of this innervation, all the necessary components such as calcium and all the proteins to build the collagen that we're going to need in there, those osteoblasts are going to be working really hard. And so when they start working really hard because the blood vessels are there to supply them, we call that the primary ossification center. So we're going to add our step 3 here. Let's do it a little bit more better here. Number 3 up top, we're going to say blood vessels innervate medullary cavity forms primary. I'm going to put 1 and degree to mean primary. Primary, ossification center. Okay. Cool. All right, and in the center, we got spongy bone. So spongy bone is going to be now forming in that primary ossification, but this is enough. This is enough. All right, we move on from here. And with that, where is my little pen? Okay. And as we look further, you can see that the full medullary cavity has finally formed, and then you can see that our metaphyses has started to create a boundary. And so we're going to list number 4, metaphyses. And then I'm going to put cartilage. Cartilage. And then we are going to, what was I talking about? Oh yeah, right. And so this creates the boundary between the two. And so this is where your metaphyses is formed. And you can also see that this is going to be a very useful site soon, because you're going to see that when you are as an adult now, that there is always, before puberty ends, there is always going to be this little bit of cartilage there. And then when you finally reach adulthood, when the end of puberty, around 25-ish, this completely seals shut. And so as an adult, this is what your bones actually look like. And as you're growing, this is what they look like at that little region. And so during infancy, so here you can see that the metaphyses, let me get back to where I'm at before I start jumping around. That the metaphyses now is going to start making sure that we have a specialized area of cartilage for growth. And then next, number 5. And so with number 5 here, let's add up here. There's have more space to write. Do I have a lot to write here? No, we don't. And so you can see now you got our ossification centers and the trend follows again. And so within the epiphyses, before we actually talk about this cartilage, I just kind of want you to see that that's what's happening there. And when you look at our epiphyses, it's just the same thing all over again. Blood vessels innervate, but instead of innervating the medullary cavity, what do we innervate? The epiphyses. Very nice. And I'm going to put both. Both. That way you remember both. We call that the secondary ossification center. All right. And then we get to 6, and we have to address 2 things here. 1, formation of articular cartilage. Recall that our articular cartilage is this cartilage up here on the humerus bone, on the end of bones, that makes sure that there's no grinding between the actual bone tissues themselves. The cartilage is a boundary. And so you can see how it gets there into adulthood is that you can see that there's cartilage still here as it's growing. And so into adulthood, that articular cartilage just gets left at the very top. And that's how it ends up getting there. So at number 1, you can see that we have our articular cartilage begins to form. Formation of our articular cartilage. Number 2, we now have our epiphyseal cartilage. And so you can see that this metaphyses retained these cartilage cells, and then they progressed into what we refer to as the epiphyses now. And so the relevance of this is that the cartilage is how bones grow in 2 directions. I wish that they showed this one in the top portion, the proximal, and the distal portion. But again, this is what it looks like also at the bottom. And let's see if we can get away with something very quick. Let's see if this works. Take a screenshot. And can I just copy it? Nice. And paste. Nice. Let's rotate it. Cool. And so what you're seeing, what you have to imagine at the end of your humerus bone, and I know that this doesn't look like the trochlea, it doesn't look like the condyle that's down here, the capitulum, and so all of that is missing, but otherwise it would look just like this right before the epiphyses, and it would look like this right before the distal epiphyses. And so these cartilage cells, if we zoom in on them, this is what we see. We see this here. And so these chondrocytes are going to keep growing and doing that interstitial growth, right? They're going to grow within the matrix. They're just going to divide, and then the cells are just going to keep expanding. And then the osteoblasts move in and say, hey, get out of the way. And so as you're growing, the cartilage goes in that going up in this direction, and then the osteoblasts are building bone in the same direction. So eventually you make it into adulthood, and then you can see that the osteoblasts, finally, when puberty is done, they built it and got rid of all the chondroblasts that are there and the chondrocytes, and you're left with no cartilage in that little space anymore. And so let's clarify our notes here. Epiphyseal cartilage is present and remains until the end of puberty. End of puberty. Puberty. Dang it. Sorry, my pen's getting stubby. So I can't do ours. And then we'll just add it to 6 here. Number 3, at the end of puberty, puberty, colon, epiphyseal cartilage. Oops. Cartilage. Epiphyseal cartilage converts to the epiphyseal line. And that's really the end of this segment. So again, remember that this is the formation of long bones. That epiphyseal cartilage is the main reason that they can grow in opposite directions. And so as you're growing from infancy, your humerus, as an example, is growing from a shorter arm bone to a longer arm bone because of that little epiphyseal cartilage that's there. And all right, let's move on. This text goes with each one of those pictures. The numbers don't correspond to what I say. I simplify it as easy as possible. But if you, after that little review, if you review it yourselves, a little by those notes, by looking at the photos and how they apply, when you read this actually will be easier to understand. So I promise if you read my notes and memorize them in the steps that we talked about, then this reading will be a lot more easier. So make sure to go through this once you sort of memorize our easy steps. And so we move on. And next we have our intramembranous ossification for the last method of bone formation. And it must be addressed because this is way different from the model or the thing that we just saw, because this type of development, or these bones in particular, the dermal bones, these are what will eventually be your flat bones. And so these flat bones are going to be the ones that we learned today. What's the one on the very front here? Frontal, with the outer. Parietal, the one that makes the ear hole in essence. Our temporal. And so you can see that these are how these bones form. These are also called dermal bones. And I thought I wrote it here, not seeing it. Find it, oh, here. And so intramembranous ossification, that's the one we're on. One of the major points here, it does not use cartilage. It does not use cartilage as a model, and that's why it's worth mentioning, because it builds bone in a different way. It's a simpler way, but almost the same, slightly different. We call bones that are made by this method dermal bones. And an example of this would be flat bones like frontal, parietal, Albright's skull bones, etc., right? Skull, cranial bones. Thursday lab, this is what we start on Thursday, so you may not know these just yet. Frontal. And it also makes our collarbone. What's our collarbone? Our clavicle. So you can see our clavicle is made by this method too. And let's add it. Why not? Nice. All right, let's move on. Clavicle. And so the picture on my screen that you're seeing is a tiny little fetus developing within the womb. You can see 10 weeks of development, and then you can see 16 weeks of development. And you can see that you can see different levels of bone building throughout from 10 weeks on my photo. I know that yours doesn't have color, but 10 weeks to 16 weeks, you can see a much more profound skeleton starting to form. And so that ability to see those first sites are what we refer to as ossification centers, just like in the previous example. And you can even see the long bones are undergoing their ossification, but these long bones, they're undergoing which type of bone growth? This one, endochondral ossification. Sorry, we should label that. I don't know why the label got cut off. Endochondral ossification, that should be on this page. That's the topic here. Let's do this for me. And let's clarify that well. Oh, wrong freaking page. Here. Here. Here, that's the topic of this topic. This is the growth called endochondral ossification. It uses cartilage for bone building. That's going to have to be your giveaway for which one uses cartilage in the beginning as you're learning this. And then these are the steps for it. This is going to be referred to as intramembranous ossification. And then so back to what I was saying, these are the long bones and they are building to endochondral ossification, the method we just saw in the previous pages. But again, the star of this page is going to be the flat bones and the clavicle bone that we just saw. And also even the mandible is another example. And so what do we need to know? Almost the same thing occurs, but one thing that we have to keep in mind, let's reestablish our vocab. Osteoblast build bone. Osteoblast, they come from the stem cells. And I already gave it away. So mesenchymal cells always means stem cells. And so these stem cells can turn into these osteoblasts. And so with that, these osteoblasts do exactly what they're good at. They lay down immature bone, which is called what one more time? Osteoid, and that's what we're seeing. Immature bone is being placed by all of these osteoblasts. Every single one of these cells are osteoblasts, all laying osteoid. Next, that whole entire little centralized region is referred to as the ossification center. So this is an ossification center, and that's a big difference. Is then the last one you only see two, just where they need you form in the beginning where the blood vessels innervate, and then in the epiphyses. And then in this example, you see them everywhere. So that's why they're all just called ossification center. And then simply they grow and then connect. That's it. They're growing. You can see that they're getting larger in mass. And then blood vessels begin to innervate. And when these blood vessels are innervate, we're also starting to see these pointy regions starting to reach over and envelop the blood vessels. So all of these little like hilly regions are all called spicules. And so these spicules are simply, think of them like fingers or something like a growing, like an amoeba wrapping around, that eventually we end up with this image, that they're all the capillaries are completely embedded within osteoid. And finally, if our osteoblasts get trapped, what do we call them? Osteocytes. And so other than that, our blood vessels just begin to expand, and then spongy bone forms, compact bone forms, and then we're seeing our two layers of the periosteum. And so what we need to know can be easily determined by the highlighted regions in our notes, is that step number 1, that we have our ossification centers form because our osteoid matrix is becoming mineralized to form bone matrix. I guess this is the statement. Mesenchymal cells turn into osteoblasts. Osteoblasts lay down osteoid matrix, and then it gets mineralized, and we call that an ossification center. And then when it forms those tiny little finger-like struts, they are going to trap or create pockets to trap those blood vessels, and so those first signs of formations of those is going to be your step 2, spicule formation for step 2. That's really the only take-home I need you to know there. And then number 3, finally, our blood vessels get completely surrounded because the spicules fused, and they created a pathway for those blood vessels to enter the area. Now that those blood vessels are there, they're capable of providing all the nutrients that those osteoblasts need to develop bone. And so you can see why they're called ossification centers, because once those nutrients arrive, they can just build bone. And so they embed those blood vessels. And so what do I want to add here? Let's keep things very light, and let's say this for number 4, spongy bone formation. And next semester, I'll simplify these. I feel like they're so complicated. Results in spongy bone formation. That's our number 4, our take home for this one. And number 5, it's going to be, what can we pick out of this? We'll do formation of compact bone. There we go. Formation of compact bone. And keep it light. On the exam, I'm going to put these clues in a different order. You just have to know the order of these. So make sure you pick just what's highlighted. That's going to be what's really going to be in a different order. You should know the orders of these steps. And then you must know example bone. We have frontal and clavicle. And we'll leave it at that. Let's not add more than that. And a big point of fact to know is doesn't use cartilage blueprint like endochondral ossification, like the other process for long bones. That's a major take home out of this. Sorry, I ran out of space. Ossification. Doesn't use cartilage blueprint like endochondral ossification. All right. And so for our fracture, when we're looking at the fracture, we have 4 steps in fracture repair, and they're all just going to involve a lot of terms that we have to know, but I am having second thoughts about this page. And you know what, this semester, do not worry about this page. And maybe actually for blood, it would actually be pretty cool to talk about all together with white blood cells. Yeah, so that might be a good idea. So you know what, for this one, we're going to put a pin on this. And that's it. Makes me kind of sad. But if we have time on Thursday, I'll fit in. Otherwise, I do want to move on to joints and get started with this. And I feel like that page is going to take up all the time. Yeah, so put a pin on this. We'll see if we add it to this next exam. We should. And we'll try. And so now we move on to a completely different chapter, and you're going to see a lot of these things. This is going to be a little bit more simpler. And this table sums up almost 40% of all the material you need for joints, believe it or not. And there are 2 aspects to this when you look at this table. When you look at functional category, you are talking about mobility. And when we talk about structural category, we are talking about stability. Mobility and stability. And so you can see that some of this is going to sound familiar. We have arthrosis, arthrosis, arthrosis. Some of us might have heard this before. And so this is going to refer to something that has to do with joints. Arthrosis, arthrosis. And if you sort of start seeing this word, a lot of these terms aren't so intimidating. And so arthrosis, arthrosis, arthrosis. And so with that, this side is going to be mobility. Synarthrosis implies no movement. So low, very low mobility. If anything, it's absent. Then we have little movement, amphiarthrosis. And then finally, We have diarthrosis, which are the most mobile joints. And so this really becomes a scale. And so I'm going to draw an arrow here, going down, pointing that way. And again, this is going to be most, and this is going to be least. Least. And I call this a scale because no matter what joint you're looking at, when you look at all of these, if you're comparing them, they're going along a mobility scale where this one is the most mobile. These are somewhat mobile. And then these here have little to no movement, essentially no movement, really. No movement. And so all of these can be classified functionally. You know some of these already. That's already there. What's the name of this? Just humor me here. Suture. What's the name of the one back here? Anybody remember? Lambdoid. What's the one that goes up here? Sagittal. And what are these little bones that get stuck between the sutures? Sutural bones. And yeah, they're like little islands, but they're sutural bones. And so you can see that this structural category is one that's pretty simple because you already know it. Suture. And so you can all imagine a skull. Do you really see my parietal bone moving around and flipping over with the frontal lobe? They really don't move at all. And so that's an example of a structural category. So you can see how I can ask you 2 questions for just this. If I ask you for the structural category of this, you answer suture. If I ask you for the functional category of this, what do you answer? Synarthrosis. Synarthrosis. Let's do the next one. This is going to be the tooth, and it's inside the alveolar process, that's the socket simply of the maxilla or the mandible. If you're Thursday lab, we're going to go over these a little bit later, or you're going to see the mandible a little bit later. But otherwise, gomphosis is the joint between a tooth and that socket. And so you'll notice that your tooth, unless you maybe had some sort of procedure done like braces, you might have some wiggly teeth, but otherwise, for the most part, these are not supposed to be moving around. And so these are also going to be functionally classified as synarthrosis. So you can see that all of these, if I ask you about the functional class of any of these joints, you are always answering synarthrosis because they have no movement. But they have individual names. And so the reasoning or the logic behind the name is that if you look at the term up top, this is held together by fibrous connective tissue. This is held together by cartilage connective tissue. And this is held by bone to bone, probably fusion. We'll see that in a sec. And so this is probably like dense regular as an example. So there can be dense regular, keeping this very well attached here. And so suture. And gomphosis, again, also a fibrous one. When we move on to the next one, cartilaginous, this one is going to be a connection between, what's this structure here in the dead center of our body? Sternum. And so you can see one of our ribs here, and what are these cartilages on our ribs called? Costal cartilages. And so you can see that it actually connects the bone to the cartilage. It connects this bone to this bone. And so it has a unique name. It's called synchondrosis, chondro implying that cartilage. And so it's a cartilaginous joint. And so it connects bones by cartilage. So it's called synchondrosis. Its functional classification is synchondrosis once more. Synarthrotic, sorry. And then you might hear the words synarthrotic and synarthrosis. They mean the same thing. Next, we have bony, and bony is going to be synostosis. Synostosis, and synostosis is going to be where you have fusion of the frontal bone. Thursday lab, I know you may not know this quite yet, but the frontal bone is made out of one bone. You might have already known that. But the reason it matters and it's worth mentioning is because when you're a fetus, we saw that there's going to be a very soft tissue opening right about here. What's it called, Lab Tuesday lab? What are those soft tissues called? Yes, I heard it right now. The soft spot? Anybody remember? Is there no bravery in this classroom? Our fontanelles. And so our fontanelles, they'll eventually fuse with the sutures, and then it looks like one bone all together. And so that's an example of synostosis. Synostosis. You really want to separate that first part, syn here, to really help you with spelling, recognition. Yes, for those at least. And so syn in Latin implies together. Together. So that means they move together. They're not really going to be, one bone isn't going to be doing its own thing. It's going to be moving together. Synarthrosis. There's no movement in between the joints. If you're going to move that tooth, the whole mandible has to move. If you're going to move that joint, your whole head has to move. So that just doesn't apply. Synarthrosis means that they move together no matter what. Amphiarthrosis is going to be slight mobility, and so you're going to see it in an easy place. This one is a little bit, actually it's not easy, but this is going to be the pubic bone. We haven't addressed it quite yet in lab, but where they meet, there's going to be a little bit of fibrocartilage there called the pubic symphyses, and this allows for a little bit of movement, and so this structure is called pubic symphyses. It is on your list for lab for next week. So you can see that the symphyses is why it's called symphyses here. And again, it's made of cartilage, fibrocartilage, pubic symphyses. So that's why it's called cartilaginous. This one's a little bit tougher to sort of learn personally, I think. But this right now, what you're seeing is the back of the, looks to be, is it upside down right now? Sorry, give me a second to really make it out what I am seeing here. I feel like I'm seeing the back of an elbow here, and this is... So you have your two joints. You have this elbow joint that does flexion, or does this flex, right? Like flex, we'll learn that word later, flex and extend. And then the other one that does that at the same location is your knee, and so you can bend your knee. And then you can straighten your knee, sort of the same function. And so behind the knee and behind also that elbow joint exist ligaments behind on the olecranon side and also on the popliteal side of the lower end. And the ligaments that connect them are called syndesmosis. But tell you what, since this picture is not clear, we're going to put do not need, and let's move on from it. Do not need. Just because if the picture stinks, I'd rather just not ask it. And then finally we made it to, I think what's the last 30% of the material is synovial joints. Synovial joints are special because they provide profound movement. So if you use our SAD scale, on the scale, they're the most mobile, and this is going to be diarthrotic or diarthrosis. All synovial joints are diarthrotic. Even better, only synovial joints are diarthrotic. You should never be calling synovial joints anything else. Nothing else applies. Nothing, just diarthrosis. And so to use our notes, some things to clarify. Remember that the word articulations is a fancy word to imply joints, meaning where two bones meet. Two bones meet, two or more. The joint or the articulation is where there might be some mobility or strength of attachment. That's why even these are considered joints. You might have always thought of a joint as like, oh, it has to have some mobility, it's the part that moves. But in fact, it will always really mean just how are bones connected within each other. And then the next vocab word to apply here is range of motion. That every single joint has some ability to move or no ability, and that's its range of motion. These that are labeled synarthrotic technically have zero range of motion, but they still hold bone to bone together. And then if we compare it to the extreme, synovial joints are incredibly mobile, therefore they have a large range of motion. Next, we have this SAD scale. That's just what I personally call it. That's the mobility scale that you're seeing here, least to most. And so when we talk about the functional classification, you can see that I call it on the SAD scale, and that because I use S, A, D. And it helps you remember which one's the most mobile and which one's the least mobile. And so this is a nice little way of illustrating it like this, right? And then most and least. And remember, this is mobility. The SAD scale. And each one's defined for you down here. And so this is everything you need. Know the specific example, except for the one that we cut off for this, again, for this semester. And only know the ones that are in the table. All you need to know is understand how to apply these terms to these joints. And so these are just written descriptions of those very things. You really can get away with just knowing this. But I would just once read through these notes as you look at this table. And remember, you do not need to worry about syndesmosis. Do not need to worry about syndesmosis. Do not need. And I'm going to put 2023 so that this is on recording. So if you're listening to this in the future, you probably have to know this. All right. And sorry, I'm already scolding my next semester. All right. And so with that, we are almost essentially done with this whole chapter. And so synovial joints. Now, synovial joints, this image sums up what you need. Learn the labeling behind this image. Let's orientate ourselves first. You can see that we have our compact bone on the outside of this bone above. This could possibly more than likely be any bone, honestly, just that has a synovial joint. And I know that it's a long bone because I'm seeing this. What was this line called that's in the epiphyses? The epiphyseal line. What used to be there? What type of tissue? Cartilage. And cartilage was there. And then it's sealed after what life event that we all go through? After puberty. And so this is what we're looking at. We're looking one bone articulating with another. And so you can see that they have the usual structures, articular cartilage. We already know this one. It prevents degradation of bone from the one above or the next one articulating it. So with that, synovial joints are special, and that's why they require their own segment. And so as you look at it, that's why I say this image is everything, because what a synovial joint is, it's a container that in some areas around where bones meet is that there's this container enveloping the meeting site. And the first things that you encounter from the superficial portion are going to be simply just ligaments. Ligaments are going to be, again, dense, regular connective tissue, those fibroblasts and fibrocytes making collagen fibers, and they are connecting bone to bone. And so you can see the ligament connects them, and so you can see it gives integrity and encloses this capsule, the ligaments. And as we look inside, we're going now from superficial, and now we're going deeper. Once we've gone through the ligaments, we are now looking at this other layer. That layer is going to be called the joint capsule or the articular capsule. And it's going to be the capsule that, again, is going to surround the articulation. You can see it on both sides, that now this articular capsule has created an inner space on the inside, and this inner space is going to have a fluid inside called synovial fluid. And this synovial fluid provides downward compression, like in the same way that you would imagine how hard it is to compress a water bottle. I don't have anything to show you, probably except this, that if this was emptier, and so if you look at these two together, or these two bottles, that if you're looking at this one, if you were trying to smash one by like stomping on it, which one do you think would be easier to destroy? The one on the left or the one on the right? Why the one on the right? It has less fluid. If you had a water bottle and you try to destroy it and crunch it, it'd be impossible. That's what is going on with this capsule, is that this fluid is also allowing some downward compression so that you can't just easily smash the bones onto each other. And so this synovial fluid does a few things. Among those is going to be that it provides some structural integrity to the actual synovial joint. And with that, that fluid has to come from somewhere, and that brings me to the last layer that I skipped over, because again, this is like just layers that you have to learn. Ligament, then you have the capsule, then finally our synovial membrane, named easily synovial membrane because it creates what fluid? Synovial fluid. And so that synovial fluid, alongside that downward compression strength that it contributes to, is that it also is a lubricating fluid. If you were to feel it, it would feel oily. And so it sort of allows those articular capsules to be grinding against each other without really too much damage occurring to the bone, specifically the periosteum of the bone. And so with that, these are the main components. This is what I want you to understand here. These are main components that all synovial joints have these. All of them. They just have it in different combos. And this is something that you don't need for the exam, but it's something that you should understand, is that you have many synovial joints. You have many synovial joints. With these components. But big but is that they have them in different shapes and combos. Because shapes and combos. So it has like these. This is the recipe for a synovial joint, no matter where you find it, but it has it in a unique manner to compensate for where it is. And I'll show you some examples of this in lab, but you're not tested for it in lab. But during the joint review segment we do next week, you'll see briefly that you'll just see that synovial joints, like the mandible connecting to the skull, is a synovial joint, and also the elbow. So it's sort of worth seeing both of them together. And the synovial functions of the synovial fluid is lubrication, shock absorption were the ones that I gave you, lubrication and shock absorption, and then nutrient distribution, that this allows for the cartilage. This cartilage, it needs to receive some nutrients to build itself. We know cartilage cells, chondrocytes, need collagen, and so they need protein, amino acids to build it. And so the nutrients, the blood vessels are innervated here. The blood vessels drop off their nutrients, and then they repair the articular capsules if possible. And that's why joint repair is so hard and difficult for the body, because blood vessels do not directly fix these things. They're not directly attached to the inner components of the synovial joint. They are really providing the nutrients only through the membrane and whatever they place in the fluid. And so it takes forever for joints to heal for that particular reason. And so with that, we'll end it here, and then perfect. And then we'll continue on muscles to conclude lecture 2 exam.